Okay, hello everyone. As mentioned, this is our last session of the course. A little bit excited, but a little bit sad. I'm sure you're happy that we have come to 12 hours of AI in medicine training at this point, by the end of this session, that is. But yeah, you might have seen me around. My name is Ehsan. I'm an MD PhD candidate at the University of Alberta. And I'm also the co-founder and director of research and education for the AI and Medical Systems Society, which has brought you this course. We've been doing a lot of work in the research and education portfolio, one of them being this course. We are working on a couple of other exciting things in terms of education, and also we're sort of ramping up some of our research portfolio as well. So if anyone's interested after learning about the course and stuff, and you want to be a part of this, help out with either the course or the or other educational programs we have or research programs we have, we're always looking for more people that are passionate about this. So please reach out. I believe I do have my email at the end, but if not, I will share it in the chat afterwards. But let's get started about today. So like today is gonna we're just gonna do like a sort of a tour of the applications of AI in medicine, and then we'll take a bit of a break and we'll then go through some of the opportunities in terms of doing AI work at the University of Alberta, or AI in medicine work at the University of Alberta. Okay, so outline, like I said, general applications of AI in med. You're probably experts in this by now, but we'll go through them really quickly. Applications of AI in medical research is another area that at least I'm very passionate about, and I'm sure a lot of people want to know how they can use AI in medical research, which has been very, very interesting for within the last few years. Some ethics of AI in healthcare, which we've sort of maybe sprinkled it around a couple times in some of the previous lectures, but we'll go through this a little bit in a little bit more detail. Having said that, ethics of AI in healthcare in and of itself would probably require a whole course. So I won't go into too much detail, and I'm also not an ethicist, so this is going to be sort of a brief overview of it. We'll talk a little bit about why AI literacy matters and what is like what even is AI literacy. And I think this is you might actually ask that, why is this here? This is something that I've been teaching as little lectures to a lot of health sciences students at the University of Alberta, as like guest lectures, but we're trying to incorporate it a little bit more widely in different courses. And we also decided that we should include this as part of this course too, but we didn't do this in the beginning because these weren't developed yet. So that's why this is happening here. But essentially, at the end of the day, we want to make sure that everyone that comes out of this course has that basic AI literacy, at least in terms of how to use it, when to use it, what are some of the frameworks, and all of that, and especially as it goes into in terms of the ethics of its usage in healthcare and health research. And then what we aim to achieved with this course, and whether we have hopefully achieved those or not. And then how can you start using AI yourself, as well as that lab tour that I just talked about, in terms of what are some of the areas of research that are happening at the University of Alberta in terms of medical AI. Okay, let's chat quickly about some of the medical applications of AI. This is something that these are some of the areas, I guess, that AI has been used in medicine, and this list is growing, and a lot of these tools are also evolving. So this is by no means an exhaustive list, and by no means it's that up to date. As I'm sure you know, AI tools are evolving every single day. You've probably heard about new models coming up every day. Very recently, I'm sure you've heard about Claude Mythos that's going to come in soon. And we have some worries and we have some excitement about some of these. But anyways, I won't go into too much detail on that. But let's chat about some of the medical applications of AI. So AI can be used in terms of making our operations a little bit more efficient and optimize our workflows. For example, if we're doing triaging, which this is actually happening in a lot of different areas in the world. China has been doing really well in this sense, but in Canada, we've actually started doing some of these as well, especially in Toronto. There's a lot of triaging using AI that's happening as well. Diagnostics and imaging, one of those like earlier areas of actually AI in medicine usage. And a lot of people at this point, I think, have forgotten that we've been using AI for a lot of diagnostics and imaging, but this has been an area of AI that has been that has evolved over the years, and it's been doing really well. Treatment planning and personalized medicine in terms of designing therapeutics or figuring out how to use them or how to repurpose them, which goes into a little bit of drug discovery as well, which I believe I do have that as a category here. Preventative medicine is also an area that AI has definitely permeated into. There's predictive analytics and risk assessment. It goes into vaccine development and also looking at vaccine uptake and public health measures that come with that. There's a lot of data in there, and there are a lot of patterns that AI can actually help with those. There's remote monitoring and wearable technology. Again, this has been an area of AI in medicine that has been around for a very long time, and I think we've had made a lot of strides in this category as well. Virtual health assistants and chatbots. I mean, everyone uses ChatGPT for one reason or another, and I'm sure lots of people are using it for health, which I actually do have slides on what the percentages are based on what OpenAI has released as well. So we'll go through those in a little bit more detail, but health assistants and chatbots have been used in medicine, or AI-based chatbots have been used in medicine for a very long time. And then management of health records and processing and analyzing these unstructured data that we usually have in our health records has also been an area that AI has definitely permeated into as well. So let's do a quick sort of run through of some of the algorithms and models that have been in use in AI in medicine. So, for example, this is a rapid stroke detection, I guess AI based software. It's VIS-LVO, which is for large vessel occlusions, for example. The patient gets a CT angiogram. AI essentially triages the scan, and then the alert it sends an alert to the care team whether this is something that they need to worry about and they have to do something quickly or not. And how does it perform? The PPV is 0.75, so there are some false positives. The NPV is 0.98, so it doesn't miss much. But essentially, this goes back to what a lot of us are trained in medicine for, and that's the time is brain. So you gotta make sure that you're doing this quickly, and so this sort of software and this sort of algorithm helps with making sure that we're detecting these things quickly. We're not letting it sit there. And PPV and NPV, they're positive predictive value and negative predictive value for those of you that don't remember. And then this is a surgical safety algorithm here, the go no go net. So essentially, it's used in laparoscopic I guess surgeries, and it sort of tells you that where is a safe zone that you can do dissections that won't cause major issues, and where is a red region, which is essentially a region that has a high risk of causing a major injury. So you can see here when they're trying to do this laparoscopic injury, they go into areas that are green. So the prediction using this convolutional deep neural net is that those areas are not going to result in major bleeds, as opposed to where the red is, that's like a no-go area. And then this is like another safe zone heat map that sort of tells you that area is pretty safe, as opposed to any other area around it isn't. So this, as you can imagine, can be really, really helpful in a lot of different types of surgeries. It can reduce the complications we get from a lot of these surgeries, and some of the issues that we might actually have during the surgeries themselves. And I believe if they haven't changed the data that they've trained this on, at least the latest information we had on this was that they'd used 308 anonymized videos from 37 countries, 153 surgeons, and 136 different institutions. So that's a lot of different types of data, and kudos to them for using that much. Not the 308. That's probably not the biggest data set you'd see, but having it from 153 surgeons and 136 different institutions, that means the videos that they've gotten, the images and the data that they've gotten is not going to be exactly the same across the board. So it's really nice that they were able to put all of that data together, and make a predictive algorithm like this. And I'm sure you remember the convolutional neural networks are used very widely in a lot of image and video based AI tools in medicine. And yeah, so this is a little bit more information about that. So in this case, we were showing the laparoscopic cholecystectomy. It essentially identifies those safe and unsafe or go no go tissue regions, and it performs pretty well. It has 90% agreement among human annotators, and has equivalent performance to humans. Now, what exactly that equivalent performance means, you got to look into the paper for sure to see that, but sometimes they don't report exactly what they mean by equivalent performance. It could be 90%, it could be 75%, it could be 99%. So that's also an important aspect to keep in mind when you're looking at any sort of AI algorithm that you want to use in a clinical setting, that it has a really high performance rating overall. But like I said, it reduces errors and complications, which is the main thing about the usage of this type of algorithm. Automated pathology is another area that you've definitely heard about AI being used in medicine. Pathology and radiology is sort of the two of the biggest things that AI is in, and obviously cardiology. A lot of people forget to talk about cardiology in there, but cardiology has been at the forefront of using AI in med for a long time too. But yeah, so this is histomic atlases of variation in cancer, or HAVOC, that's developed in at the University of Toronto. Actually, it automatically segments histology slides, and it essentially tiles them into little images, and then they're colored based on tissue type. But then they have another algorithm they've built called Pharaoh, which is the phenotypic and regional analysis of histology. This is a crowdsourcing platform, and different users actually develop these additional AI tools that they can develop, and then they have been able to use this to further classify the regions that HAVOC can classify. So this is the website for it. It's like I said, it's developed by the Diamandis lab at the University of Toronto, and you can access that website and sort of look at what sites they are supporting. I'm sure these sites are going to change in the near future, and more things are going to be added to this. But like I said, it's a crowdsourcing platform, so there's a lot of interest from outside of that lab that are trying to put in their developed algorithms in there too. Face2Gene is another AI tool that has been used in medicine for a while. It essentially identifies genetic syndromes from facial features. As you might know, a lot of genetic syndromes show up with dysmorphic features in the face, and so it makes sense to try and actually identify those through pictures of the face. So essentially, once you take a picture, it sort of tells you that it thinks this, like, essentially it classifies how the differential diagnosis, and tells you that it thinks it might be KBG in this case, but it's possible it's Noonan syndrome as well, or it could be Smith-Magenis syndrome too. And you can go in, and it actually gives you a little bit more overview. This is a different case, a little bit more overview of what it thinks it could be and what the diagnosis was, potentially what the gene-related phenotype was, and it does like a case analysis for you as well. And if it's some sort of molecular diagnosis has actually happened, then it shows you that that's the case too. This has been used in clinical genetics actually for a long time, and I'm sure they're evolving their algorithm as well. I2Gene is another algorithm that sort of predicts genetic variants from retinal images. And so how it does is you give it your fundus images and your OCT images, for example, and then based on like the infrared image or the FAF image or the OCT image, it sort of tells you which genes it thinks are implicated in whatever this disease might be. And then in the end, it gives you the sort of like an overall diagnosis, or rather an overall gene that it thinks is responsible for whatever issues you're seeing in the images. And then the accuracy, excuse me, the accuracy of the algorithm when I took this slide, which was a bit ago, so this might have changed, was at 88% of the cases, the correct diagnosis actually was in the top 5 differential that the algorithm was giving you, which is pretty good. Having said that, top 5 is probably not the best measure. A lot of people are now challenging that, and they are requesting you to give top 1 and top 2 accuracies. In this case, that's going to be a little bit lower, but obviously, like I said, a lot of these algorithms are evolving as we move as well. IDXDR is actually the first FDA-approved autonomous AI for diabetic retinopathy screening, and it's been around for a very long time. They got bought out, I think, by a different company, but they're still around. And essentially, it sort of gives you a rating of does this person need to see an ophthalmologist, for example? Do they need a referral or anything like that? And it's pretty good at recognizing some of those. Like I said, it was actually one of the first ones that got FDA approved as well. And so something like this would be very useful for rural and remote areas, for example, where there's no direct access to an ophthalmologist, and you don't want them to go see an ophthalmologist just because. If you can show from the algorithm that, oh, this probably doesn't need to be seen by a specialist, then you don't have to send them over to an urban center, for example, to get that checked. This is another algorithm. This is sort of in research mode, but they're working on making this into more of a clinical algorithm as well. But they're trying to predict exudative or wet AMD from essentially when it goes from dry to wet AMD conversion. And how they do it is for this one, they look at you have the first eye from the patient. So once they're diagnosed that there's wet AMD in the first eye, then they can then this algorithm looks at the fellow eye, and then through those observations, it can sort of tell you whether the second eye is going to turn from dry or convert from dry to wet AMD. And they're using multiple deep learning prediction models here. If you read the paper, you'll see exactly what they've done. But essentially, you give them the OCT scan. The algorithm does a segmentation on the OCT scan, and they get a tissue segmentation from that. And then these two are fed into a prediction model that has an ensemble prediction model at the end, and then it sort of gives you a conversion risk within 6 months for the wet AMD. And then you can sort of follow this along whenever the algorithm is going to tell you that there's a chance of this happening within the next 6 months. Now, is that the best use of these tools? Can we make that better? Probably. So you can still try and predict certain things if you know things in advance, 6 months in advance. But obviously that's not enough. So more probably is coming in this area to try and predict it well enough in advance that you can potentially try and prevent that from happening. AI warning systems have also been in use for a long time. I will.
Patient went for X-ray. very stable. He went down for CAT scan of the head. He came back very unstable, having shortness of breath, gurgly, wet. And all of a sudden, around 12ish, we got chart watch alert and we intervened right away. So the nurses continuously monitored, prioritize him as high alert, and it's prevent them from deterioration. It gives me a warning, a safety or added security layer for giving me a high alert. Every time I hear the alarm, I just tell the nurses, whoever has the patient, and then also inform the doctor in advance. So at least the nurse finds something, they can just update the doctor. From the first time it's been used, I could only remember one transfer to ICU. And that was a former ICU patient too. Here is AI in our unit as a project, and it's working.
So as you saw this, that was from Unity Health Toronto. So they have this algorithm already in use called ChartWatch, which predicts patient deterioration, as you heard from the video as well. It sort of looks at all the characteristics of the patient, including age, sex, vital signs, laboratory test results, and then sends an alert whenever it thinks that there might be something going on with the patient to both the nurses and the doctors. And then in terms of performances, it has some false positives as well, but it has shown 26% reduction in unanticipated mortality, which is actually pretty good. The one thing to mention here before I forget is a lot of these algorithms, you're not going to have there's not really a set sort of accuracy metric that all of these algorithms are using. So every company, every research group is going to try and use whatever metric that they think is best, or sometimes they might be a little bit more ethical than that and actually give you a bunch of different accuracy metrics. So it's also important as part of that AI literacy that I was talking about before too, to understand what some of these metrics are, as I'm sure you remember from the previous lectures in the course. But some of these metrics are actually improving too, and newer metrics are coming up as well. So keep up to date with all of these. You can use some of the AI tools to actually keep you updated with these as well. But essentially, just knowing that you can't necessarily always compare the two models together because they're just going to give you different accuracy metrics. So that's an important distinction between a lot of this. Early detection of a lot of diseases and stuff is pretty important as well. Obviously, we've been striving to do this in medicine. So for example, mood capture is an algorithm that tries to detect depression earlier than it can. So it just is like asks you a couple of questions, and then based on those, it tries to predict it. Does it perform really well? Probably not yet, but we're getting there. In terms of arrhythmias, so Apple has the ECG module on its watches nowadays, so that's been performing actually really well. And then there are some research groups that have been working on Parkinson's, early detection of Parkinson's using voice or even EMGs and how people walk and that sort of stuff, and try and detect this a little bit earlier before it actually shows full-on symptoms. Essentially, stuff that we used to call preclinical or subclinical, or even things that we decided that, oh no, this is not something we think it even might end up being this disorder. But having these tools now can actually help us try and understand these things and detect them earlier on. Of course, you know about AI scribes. I think this is one of those areas of medicine that a lot of people have heard about. I will also show this video if I can get it to play.
To start a live scribe, press the new live scribe button. Select again your template and the language of the conversation that you would like. You can have live translation as well. Press record and start your conversation. Good morning, John. How are you doing today?
I'm doing fine, thanks.
So, John, what can I do to help you?
Well, I've been having some swelling in my wrist.
Is it both of your wrists? Once your conversation is complete, you can paste in extra detail into the box and press submit. The note will be produced taking into account all the context you gave it, including the additional information that you provided and the initial conversation. From here, you can then make further commands to make edits if needed. Here I've asked Scribery to fix the cheap complaint list so that it's numbered, and I've also asked it to change the date at the end to 2024. I can also ask it to create tables for me to remind me of first-line treatment options. I can use Scribery to prompt me to remember medical information if need be, or put this in a summary for my patient. Here's an example of myself creating a table for first-line treatment options for psoriatic arthritis, with the benefits and risks mentioned as well. I can also create a patient handout for my patient in English or in French. As shown here, you can see the handout populate, and I can then take this and put it into my EMR, print it, email it, or edit it as needed.
Yeah, so this is an example of just one of the AI scribe tools that are out there. There are tons of AI scribes nowadays, and I'm sure more are coming into the clinics. Do they make mistakes? They still do, yes. And that's why that human in the loop is still very important. But things are changing, things are evolving, and a lot of these algorithms are becoming better at what they do as well. This is a significant change in terms of paperwork and administration in medicine. A lot of physicians are happy about the incorporation of these scribes. There are some ethical concerns in terms of asking the patients that AI is being used at their visit and all of that. But we'll probably get past those within the next few years, and this might become a very routine and regular part of essentially any doctor's visit. And so a lot of these, like I said, there's a bunch available out there. They're actually trialing one also at, I believe it's called Jenkins at the I guess emerge units in Alberta. So we have a lot of these types of tools, but then obviously some are more so protected in terms of, for example, if AHS gives you access to those and you can use them in AHS settings versus some are going to be available to family doctors. If you have a private clinic, you probably are able to get your own AI scribe, but obviously there are certain considerations in terms of where the data goes, whether the algorithm gets trained on the patient information you're sharing, is anything getting out of the EMR and going into the model itself that might be in a different, that might be in a cloud server, might be even in a different country or a different province. How does that work in terms of our provincial regulations? A lot of these we're still figuring out as we go. So the regulatory landscape is going to change about a lot of these. But again, these are considerations to have. Like I mentioned before, and you saw that it's their ambient scribes. They're just there. They're essentially listening into whatever is happening. They're large language models, so same category of AI tools as things like ChatGPT and Claude. And they do automated transcription of whatever is being said. You can make them essentially make you automated chart notes, and then they've been early evidence actually shows that it reduces administrative burden. It increases the quality time the physicians have with their patients, but obviously review is important at the end because you're still going to have some hallucinations or confabulations that these algorithms are going to do in the end. But like I said, I think the thing that I've probably said the most is they are getting better. Okay, and then clinical decision support. I'll show you this as well.
UpToDate has set the standard for evidence-based clinical decision support. But with the innovation and impact of AI, it's time for UpToDate to set a new standard. It's time for clinical generative AI. Introducing AI Labs, powered by UpToDate content and dedicated to the responsible testing, development, and implementation of generative AI for healthcare. Possibilities are endless, but so are the risks. So we're not doing this alone. We're collaborating with major healthcare organizations, clinical experts, and technology leaders, and more than ever, focusing on safety and trust through transparency. The result will be transformative, creating an interactive experience for clinicians and care teams that combines unparalleled speed with industry-leading validation and expertise. UpToDate is your trusted source for evidence-based clinical decision support that will continue to be your trusted partner by setting a new standard in clinical generative AI, improving today's healthcare tomorrow's technology.
I'll just stop that because you sort of get the gist. Those of you who have used UpToDate know that we usually use that as like a very trusted source. And hopefully you can get access to this. I know at least for those of you who are U of A med students, there are some talks within the Med Society and the program to try and actually get a little bit more money so we can get access to the expert AI portion of UpToDate as well. But as far as I know, it's actually I believe you might have had this as part of the lectures before, but it is a retrieval augmented generation system or generative system or RAG. And so it's actually trained on the UpToDate data, and it's grounded in like our articles that we've had access to through UpToDate anyways. So it's the amount of hallucination goes down significantly when you use a system like that. And then obviously you can get the information from wherever the trusted source is, and it can even direct you to where exactly it found and synthesized that information through. So the base of the model is still it's a large language model. It's a chatbot essentially, but where it gets that information from is the important part of that, and what the data that they use to train it is. I'll show you this other.
In fact,
one
MedCom
here.
is the first language model to perform at expert level on medical licensing exam style questions and is currently the state of the art. We are also working to add capabilities to MedPalm 2 so that it can synthesize information from medical imaging like plain films and mammographs. You can imagine an AI collaborator that helps radiologists interpret images and communicate the results.
Yeah, so this is MedPalm 2 by Google. And again, those of you who have gone through sort of trying to read a chest X-ray, we usually try and come up with a standardized way of going through a chest X-ray of, do I see any devices? Like, how do the lungs look? How do the cardiomediastinal area look, and like are there other abnormalities like in terms of bones and musculature and all of that. So for example, in MedPalm 2, you can actually upload a chest X-ray, and it sort of gives you a finding list of what it sees in the image. And so the one thing to keep in mind, though, as much as this goes back to that accuracy metric that I was talking about before, is if you remember in the video, the Google CEO is telling us about how it performs really well in these multiple choice exams that a lot of med students or residents take. Now, there's been a lot of discussion in terms of whether that's the best way to evaluate a model, because a lot of the patients don't show up the way those exam questions are. They don't, as we've been told a lot in medicine, your patients don't read textbooks and come to you, right? So this actually changes how we evaluate some of these tools as well. So don't just trust an algorithm that performs really well in a bunch of multiple choice questions. We need algorithms that are going to be good at an actual patient scenario and an actual case of a patient, rather than just something that's very much clearly written in sort of a test format. Having said that, a lot of these algorithms are actually really good when it comes to patient interactions as well. So I'm not saying that that's not the case, but it's just one of those other things that I'd like all of you to take out of this course too, that there are these other metrics and evaluation methods that you need to be aware of. And then different chatbots for sort of as virtual assistants in patient education. A lot of people obviously use ChatGPT. There are some people that still use DeepSeek, and it's still pretty prevalent in China. Claude AI is like another I guess system of models or category of models developed by Anthropic that's been doing really well as well. And it's actually interesting that when they compared responses of ChatGPT and Claude AI to cancer questions, they actually showed that chatbots can actually generate quality and empathetic responses, and they were comparable to physician responses. And you might have heard of the study where they gave a bunch of these, I guess, responses to family physicians without telling them which one of the responses came from an AI tool, which one came from a family physician, and they actually scored the AI results a little bit higher in terms of empathy. Does that actually means that AI has more empathy than humans? Probably not. That's not what you can get out of that, but it's just telling us that these tools are actually performing really well, even when it comes to empathy. And there are multiple reasons for this. You have compassion fatigue, for example, from a lot of physicians. You also have essentially like the bias of someone looking for empathy and how exactly they're measuring empathy and all of that. So there's a lot of nuances to be aware of with this, but overall, it's just telling us that these tools are doing really well. But again, as you know from before, a lot of chatbots can confabulate information. Most of them, at least the free versions, are not confidential. So you shouldn't be providing any sort of patient data to any of these algorithms unless you're perfectly sure that it is an institutionally approved algorithm that you can actually do that with them. And then this, I just included this here. MedHelm is I guess a workflow or a way of organizing and looking at different tools. And what they do is they've developed this in one of the labs, I believe in Stanford. And you can sort of look at different categories and subcategories in terms of also which data sets and then what metric. And then it sort of tells you which one of the models performs well in that specific category, and that's for that specific metric. This can be a good way of us evaluating a lot of these large language models or LLMs medically as well. And for example, in this case, this is from a while ago. GPT 4.0 performed really well, and then followed by 4.0 Mini, and then Llama was good after that, and then Gemini and QN, which is from Alibaba, and then 3.5. This is another usage of AI in medicine.
Today is an opportunity for Anne and Bill to have a conversation through our brain decoding to facilitate what we think would resemble a future use of an actual real life application of the technology.
We want to try to basically create a demonstration where we're decoding the text, the speech, and the avatar at the same time from Anne's brain as she tries to silently attempt to speak. We just trained some new models yesterday, so I need to test it a little bit.
Okay.
Because,
Yeah.
Yeah, we'll run practice runs.
The device is an electrocorticography grid, which is attached to a pedestal, which is screwed onto the participant's skull. And is the very first person to have this combination.
I think you are wonderful.
In the training lab, we really focus on restoring voice to people that have lost it due to conditions like stroke or ALS.
What we're picking up on are neural activity related directly to.
And in the interest of time, I'll just pause it there. But essentially, you get the gist. A lot of these BCIs or brain-computer interfaces are enabling this communication and movement that we would not have been able to have before because of brain damage or spinal cord damage. And these are essentially AI-powered or augmented prosthetics that usually are trained with reinforcement learning as well. As part of that is also the exoskeletons for rehabilitation and mobility assistance too in here. But essentially, this is a way to try and restore different types of function that we have otherwise. And this is some data I included from a recent study, and this sort of shows where the field is actually going. The RCTs in AI have been one of those things that have been around, or at least the concept has been around for a long time, and people have been calling for those. But now we actually have the largest RCT of AI in medicine from Sweden that was recently published in February of this year. So it was on 105,000 or close to 106,000 women in Sweden. And what they have done is they've looked at mammography from breast cancer screening. And they've compared it in two different categories. In the EU, the standard for radiology is actually double reading. I am actually not sure if we do that in Canada or the US. I don't think that's the case. It's just one radiologist that reads it. But usually in the EU, the two radiologists actually would read an exam, and they essentially compared that to one radiologist plus AI. So can you actually reduce the amount of workload that you have on radiologists using this? And they have this AI algorithm that is from ScreenPoint Medical with 2D mammography. The sensitivity is 80.5% when you have AI supported versus 73.8% when you do the standard. Specificity is 98.5% for both groups. So AI did not actually increase false alarms. They're essentially estimating that 20% of breast cancers are missed by radiologists alone. So if you're adding an AI component to this, especially in jurisdictions where we don't have double reading normally, adding AI into that workflow is going to help a lot in terms of trying to find things that the radiologist, just one radiologist might have missed. So essentially what they're showing with this data, also like important aspects of this is 29% more cancers are detected with AI. There's 12% less interval cancers missed, essentially the cancers that would happen between the two times that you would have done a test on this. There's a 44% reduction in radiologists' workflow, which is really good. And like I said, 0% increase in false positives. So this is actually a pretty good tool that can be used. Now, what else can this tool actually do, which is very interesting, is it can actually look at some of the other diseases and look at some of the other risks as well here. So these two models that we have here, for example, Clarity Breast and Mirai model, the Clarity Breast identifies 5-year breast cancer risk from standard mammograms, and then 16% of women in their 40s with normal mammograms actually found to be high risk. So it can sort of try and predict some of those ahead of time with those mammograms. So it's not just detecting the cancer itself, but rather predicting the risk. And then this other model, top 20% risk group accounted for 42.4% of interval cancers. Again, it's actually pretty good in trying to identify some of those interval cancers. And then there's fourfold higher cancer incidence in high risk AI groups versus average risk. So it can actually perform really well when you're trying to compare the two higher risk and average risk categories. But like I was saying, the cardiovascular risk is also detectable with some of these algorithms, even though it's just a I guess tool to look at mammograms based on breast arterial calcification. It can actually tell you what's the risk of having an adverse cardiovascular event in the future. And so each one of those categories gives you the percentage of even a major advanced cardiovascular event as well. So these are essentially opportunistic AI imaging, so detecting some of those secondary health threats from some sort of a routine screening that we do for something else. Essentially, you have one mammogram, but you have multiple insights from that same mammogram for other things that are not necessarily directly related to the mammogram itself. In terms of putting a case together for universal AI and mammography and sort of the obstacles to that. So in the US alone, there's 40 million plus mammograms that are done. They use, actually, now I answer my own question, US actually uses a single reader system. And then there's a growing shortage of radiologists. I mean, there's some speculation that AI is replacing radiologists, which hasn't happened, and we'll talk about it in the next slide, actually. And then the preventative task force in the US actually recommends biennial screening for people age 40 and above. It used to be age 50. And then there are FDA cleared tools, including the one that Sweden actually did the RCT on. And at scale, the cost actually would drop to about $1 per screening, which is really good. And then obviously there are some issues in here in terms of limited access. There are still cost barriers, as much as the cost is going to drop for this once it's implemented, but the implementation itself is going to cost us a lot. Transpera, as I mentioned, is the only one that's been validated in a large RCT. The others don't really have that evidence. And then there's not really a standardized follow-up protocol when AI flags a high-risk case. And then there's a risk of overdiagnosis and also a risk of over-reliance on AI, as well with a lot of other tools. And then there are large trials still ongoing to look at some of these, so we don't have the full I guess, results of all of these for now. Now, the million-dollar question of will AI replace doctors? So AI is transforming healthcare. So there's a lot of applications across healthcare, as we've talked about. It's making healthcare more efficient and more accessible. It's empowering a lot of these things that we've been talking about in medicine for a long time, preventing certain things, trying to do precision medicine, personalized medicine. It reduces a lot of admin burdens, so the clinicians actually have more time with their patients. But in the end, the answer to that question is that AI is not replacing physicians, but physicians who know AI or clinicians who know AI are replacing those who don't. And I wouldn't even call it replace right now. It's just that they're able to do more. At some point, it might end up being a replacement, but not yet. And another thing I wanted to include here is I know a lot of people get really excited about using AI for a lot of things. Do we actually need especially advanced AI for every little thing that we're using? Like, do you need to use extended thinking and like the highest model on ChatGPT to try and ask a very simple question? Probably not. So some of the problems that we have are actually solvable with basic models or even simple stats if you're doing a stats-based thing. So you don't necessarily always need an advanced AI. So how's AI impacting medical research? I was going to talk about this as well. So medical research applications of AI, it's augmenting and synthesizing a lot of medical data. It's showing biology and biochemistry in terms of drug discovery, as we talked about before. You can use a lot of genomic data and it can find out a lot of patterns in that data in those types of data for precision medicine. It facilitates clinical trial screening. I'll show you actually a tool that can do this. It can summarize the literature for you, as some of you might be using things like Open Evidence, for example, which are pretty good at trying to summarize a lot of the literature for you. It can also write papers for you. Don't know if we want to go there. I probably wouldn't get AI to write me a paper, but there are tools that I actually can do that, and they're doing pretty good. And so sometimes it's not even that easily discernible to know that this is AI based or not. But these are some of the areas that AI can be used in medical research. So if you're a nerd like me, you know this is Mr. Data from Star Trek. But I have this here to talk about synthetic data. So we know AI models need a lot of data. This is well known for a long time. You can't just train an AI model with like 3 sets of data and then call it a day. You actually need really high amounts or large amounts of data. And medical data is notoriously difficult to obtain. So a lot of it is based behind a confidential wall. You can't access it. Some of it that you can access is not structured well. And trying to get information from a bunch of different clinics and putting all of that together is not easy. There's also confidentiality and consent issues. There's obviously the ethics of using this data. If you have rare diseases, now you have even less data to be able to use. So we can sort of fake that data, right? So let's go through this. So I'll put this up for you guys. And can you spot the fake out of these? And I'll get everyone to just put it in the chat. Which one do you think is the fake? Is it the left one, the middle one, or the right one? Or you can unmute and talk. Okay, I see left and right. I also see a middle. Okay. Well, what if I told you all of you were right? Because those are all fakes. The one up here is actually the not fake one. So these are essentially bootstrapped from this main image here. So you can do pretty well with a lot of this types of synthetic data. So you can try and generate some of these, and this has been done a lot in even simple stats in terms of bootstrapping and stuff before as well. This is not new to the AI era, but we sort of need some of these tools to be able to perform better and train some of these tools better. So, for example, Synthea is a database that they've generated the synthetic patient info. They're realistic health data, but there's no restriction because these are not actual patients. So they just give you a complete medical history, medications they're using, what allergies they have, medical encounters they've had in the previous in their previous, I guess, encounters in with the healthcare system. Their social determinants of health. It's free and open source. There are no legal or privacy restrictions because these are not actual human patient data. Now, the other aspect we talked about in terms of what AI could help is drug discovery. So you see that it can help with target identification. It can look at compound interaction predictions. You can optimize structure of a lot of these drugs that we're trying to use. When there is polypharmacy, it can help us with trying to determine how these different pharmacological agents interact with each other. It can help with drug repurposing, as I'm sure you've heard during COVID. This was one of the major things that AI was trying to help with. So that's another, I guess, area that AI has been used for. And then again, I'm sure you've heard of AlphaFold. It's deep learning that solves protein folding, which has revolutionized structural biology. And we know that the Nobel Prize in chemistry went to the people who developed AlphaFold 2 and have now developed AlphaFold 3 that is widely available on their online server as well.
We have partnered with Google DeepMind for this video to celebrate the launch of a follow-up to one of the best papers ever written, AlphaFold. Now, version 3 is here and I am out of words. I'll try my best to explain why what you are seeing here is history in the making. So, what is all this about? Well, this work is about protein folding and more you'll see in a moment. The protein is a string of amino acids. These are the building blocks of life. This is what goes in, which in reality has a 3D structure. And guessing that structure is protein folding. Letters go in and a 3D structure comes out.
I'm not going to play the whole 10 minutes of this video, but this is available. I love the way this guy is so passionate about AlphaFold. But this is, I believe, from 3-minute papers or 1-minute paper, but it's 10 minutes actually. I have to look back where I grabbed this from, but there are a lot of these, I guess, YouTube channels where they go through some of the newer papers that come out. And when the AlphaFold 3 paper came out, this was generated, and they sort of talk about a little bit about how AlphaFold works and how it actually predicts protein folding and all of that. For those of you that are in basic science or are interested in more protein folding, this is something you can check. And especially if you're looking at variants in genetics and stuff like that, which has been some of the work I've done, this is an important area you can use these tools for. But speaking of genetics, there's a lot of AI tools that could help in genetics, as we showed before, the I2Gene, for example, or Face2Gene. You can have this genotype to phenotype prediction, or the other way around, as I showed with those two algorithms. AI can actually help decode the genome, because we've had a lot of problems with, for example, genome sequencing in the past, trying to identify which one of the variants to think of as like more of a candidate and all of that. So it can actually help with all of that. It can even read and write. We can even have designer organisms. I know that sounds a little bit sci-fi, but we might at some point be able to actually write a genome based on whatever genome AI tools are analyzing in the end. And then you can also have precision health as a result of integrating a lot of complex multimodal data. So you have a lot of text, you have a lot of images, you have a lot of videos, all of this together. We usually look at them in clinic, and you're trying to sort of make sense of all of this together. But there's a lot of especially foundation models that are trying to put together multimodal data and sort of try and get something out of that as well. It can be used in pharmacogenomics. It can be used in a lot of prognostication and also like optimization of the doses and treatment and all of that as well. And then current clinical trial matching, I brought this up before. So this is something called Trial GPT. It can accelerate clinical trials and then reduces patient screening time by 42.6%. So essentially, you give a patient summary to the algorithm. It has a retrieval module that looks at a lot of the clinical trials and tries and figures out which ones of these trials this patient could be eligible for. So you're not back and forth trying to figure out which one you can recommend for your patient. And then trial summarization. So Clin Digest is one of those. They have hundreds of clinical trials submitted daily, and you don't know how you can keep up to date with those. So algorithms like this can summarize some of those clinical trials, and it provides descriptions of all of those into concise summaries with references, and so you can actually use those to your advantage to try and help your patients get into a clinical trial, for example. Scientific writing, large language models can actually be used a lot for scientific writing, at least in terms of refinement of a lot of these things, making things more concise, or avoid run-on sentences, that sort of stuff. They could be used to write complete texts. For a long time, we've used them for fixing grammar. So you can get them to change styles for you or change formatting, compiling references, and a bunch of that sort of stuff. But in the end, I think the important thing is disclosure of usage. And I think the more we actually disclose the usage of these tools, the more they're going to actually be used, I think. And it's also going to result in a lot of ethical usage as well. And this is actually interesting. I just included this picture here. But as you can see, a lot of these AI tools, this is actually an image we generated with ChatGPT about a year or so ago. This is probably not what you're going to get if you ask it to give you an image today, because they've gotten really much better in terms of recognizing text in images. But as you can see, like, look at how this closes and look at what is out on the outside here. And I'm sure you might have seen that paper that came out a while ago in Frontiers in Cell Developmental Biology, and the figures that they had generated with AI and all of the issues with it. And more specifically, you could see it in text as well. So a lot of these tools are getting better. The thing I keep saying today. But the main thing I want to emphasize here is the fact that we need to disclose these. Health research, as we talked about, AI is transforming a lot of that. So they're providing alternatives to that protected data. We talked about synthetic data, extracting and summarizing the data, improving the efficiencies, and decoding certain parts of biology, empowering preventative and precision medicine as well. So these are some of the things that AI has been doing really well so far. Now, let's talk a little bit about ethics. We'll probably take the break a little bit after 6, because the second part of this is probably not going to go too long when I talk about the lab tours. But I really want to get through some of this stuff before we take a break. So in terms of ethics, so there are a lot of challenges in terms of using AI in healthcare, as I'm sure everyone's aware. So there's, for example, something called algorithmic bias. So a lot of the AI systems can actually perpetuate or widen a lot of the health inequities that we already have in our existing data. A lot of times humans can look at that and we can identify, oh, like there is a bias in this. AI tools have gotten a little bit better in looking at some of those patterns and identifying some of these biases as well. But overall, we have a lot of biased data sets, and we're feeding these biased data sets into these tools. And it's essentially the whole thing of garbage in, garbage out. So if you're giving them bad data, they're going to give you bad output. So, for example, like if a widely used algorithm assigned equal risk to Black and white patients, despite Black patients being significantly sicker. And this is mostly because of the way we've been developing data sets, and we've actually been putting together data previously. There are privacy risks. So AI relies on a lot of sensitive health data. And if a data breach happens, or if there is insufficient oversight in terms of data transfer or vulnerabilities of the cloud tools that we're using for these, that data can actually, those data can be breached, and certain people could have access to those that shouldn't have. In terms of accountability and transparency, one of the major things that has always been a question is who is liable when AI makes an error? If a physician uses an AI tool, gives the wrong diagnosis because of using that AI tool, who is responsible for this? And this is very difficult to assign that responsibility. Do you assign it to whoever used this in a clinical setting? Do you assign it to the hospital? Do you assign it to the developer and the company that developed it? So these are some things that we still haven't really figured out. For the most part, the answer is usually the provider. So if you're the healthcare provider using these AI tools, you have an extra responsibility in terms of this. So be careful. But we still are, these regulatory frameworks are still being developed as we speak. So a lot of the technology is already far beyond what we can regulate. So the regulatory aspects are trying to play catch up essentially with all of this. And then, do patients understand that AI is involved in their care? So this is actually one of the things I touched on before in terms of AI scribes, for example. So it's important for us, at least in this early stages of using these tools, to have informed consent. At some point, AI scribes are going to become a part of the electronic medical record system. And the same way we don't ask consent to ask patients, oh, are you okay if I put this into your chart? It's going to be the same thing in terms of using AI, but we are not there yet. And then sort of trying to navigate this. So there's some frameworks and solutions. So there's the Healthcare AI Trustworthiness Index, which has these measurable metrics for fairness, explainability, privacy, accountability, and robustness that you can use. Again, this goes back to the metrics that I was talking about before. There are algorithms that are fairness aware, and they are getting routine audits to make sure that they're performing well. You need diverse development teams to reduce that bias as well. If everyone comes from the same background who are developing these tools, you're going to have bias in the development too. We have like GDPR and the AI Act in EU, which they've tried to put together regulatory frameworks, but these are emerging globally as well. But there is a lot of medical AI developers don't actually have structured ethics training, and that's one of the problems I think that is in the field, and that needs to be fixed very quickly. And then, like I was saying, technology advances are outpacing these regulations that we can put together right now. And then this is from a paper that I saw a couple weeks ago. It's interesting that they looked at the AI-generated data contamination. So if you essentially keep using an AI-generated text and give it to another AI tool, and then take that and give it to another tool, and they're trying to essentially simulate how things are changing, because a lot of these AI tools were trained on the data that humans put together. And then now we're getting a lot of these data, these AI models to give us data, and then we're feeding that AI generated data into another model or the same model. So the training of these models is actually changing as well. So this is AI generated data contamination essentially. And so interestingly, what they found from looking at 800,000 plus synthetic data points is that a lot of the models end up converging toward a very generic health profile. So if you have rare diseases, if you have rare types of specific types of, I guess, managements or management pieces that you have for a patient, those are gonna essentially be gone at the end of this, because they're not represented as much. So critical findings, for example, disappear from generated content, demographic diversity declines, false diagnostic confidence actually increases. And then funnily enough, this actually becomes very obvious after 2 generations of synthetic data, and it becomes clinically unreliable. So this goes back to that synthetic data that we were just chatting about. It's important now to combine real data with quality filtering, and that would help us a lot with providing these synthetic data. But it's very important to realize that if you keep giving synthetic data to these AI algorithms, at least the way they are right now, we are losing a lot of this little nuances that we have in clinical medicine. So again, AI is not replacing doctors yet. So ethics and literacy, this goes to that that AI literacy piece that I was talking about before too. So if AI systems can be biased, they can confabulate information, they can erode data quality. It's then important for us to understand how AI works, and it's an essential thing, not necessarily just an optional thing that we should have on the side. And that's why we're providing this, or we have provided this elective for you folks. So healthcare providers need to be able to critically evaluate the outputs of AI, but also learn how to interact with these tools and how to input information in them. Patients also need to understand like the limitations of using AI for health information. There's lots of data actually on how patients are using AI tools. I'll actually go through the OpenAI data in just a slide or two. And then we need to understand that bridge between the promise of AI and the safe implementation and application of it. And that's the AI literacy piece. So let's look at some of that data that I promised you before. So OpenAI released this in January of this year, actually. And so there's about 800 million or over 800 million regular ChatGPT users globally. 230 million plus of those actually ask health and wellness questions every week. And then 40 million plus people use ChatGPT daily for health questions, and over 5% of all ChatGPT messages globally are healthcare related. And then a little bit more specific to the US, 3 in 5 US adults have actually used AI for healthcare in the past 3 months. Now, the important piece I want to mention here is this, and is this piece. 7 in 10 of the health conversations happen outside of normal clinic hours. So this shows us a gap that exists in the current, I guess, way of providing healthcare. When you don't wait outside of normal clinic hours, people don't have anything to have access to. So what are they going to use? They're going to try and use some of these AI tools. So it's important for us to realize that, sure, like patients are using these tools a lot of times during normal clinic hours, but a lot of them are using this during non-normal clinic hours. And imagine what would happen if an AI tool would give you a harmful response and tells you, oh, this is not a big deal, you don't have to show up to the ER, and then they don't, and it was a heart attack or a stroke. Or the other way around of telling them, oh, no, this is a very big deal, you should show up to the ER right now, and then they show up and they get through triage and they're like, oh, this is a false positive, we actually don't think you have anything major. So these are important. What people are asking ChatGPT about health? Again, this is more American data. 55% use it to check and explore symptoms. 48% use it to understand medical terms. 40 plus percent use it to learn about treatment options. And then again, because this is more American data, about 2 million messages per week are about health insurance in terms of plans, claims, and billing. And then usually the areas that have hospital deserts, they have a lot more of these messages that happen in those areas as well. Now, how does Canada compare to this? The Canadian Medical Association did a survey on this actually this year as well. So they say they've concluded that about 89% of the population in Canada go online for health information. About 50% use AI to diagnose or treat health issues, and 27% actually trust AI for accurate health info. And I haven't gone into this to explicitly figure out how they figured this out, but they claim that you're 5 times more likely to experience harms if you're following AI health advice. And that's a significant number. So these two numbers are actually things that I'm a little bit concerned about, and these are some things that we need to sort of do some more studies on, try and figure out what is happening there. Health-specific tools are coming in as well, like health-specific chatbots. So, for example, ChatGPT Health has been launched in January. If you're not on the wait list, you could go sign up to be on the wait list for it to be released to you when they do release it. It technically is supposed to securely connect medical records and wellness apps. And they say that they've developed it with 260 plus physicians across 60 countries. It's not intended for diagnosis or treatment. It's just designed to support, not replace medical care. Now, are these actually true things that OpenAI is telling us? We don't know. And then in terms of physician adoption, in 2024, 66% of US physicians used AI for at least one use case, which was up from 38% in 2023. Now, obviously, we have a lot more availability and accessibility to these tools, so that sort of makes sense, but also that it tells us that a lot more physicians are now using these tools. Some of these risks that we've talked about multiple times are still here, like they can hallucinate and give incorrect information. Like, for example, like patient was hospitalized from bromide poisoning after following ChatGPT advice last year. And I'm sure you've heard of a lot of these horror stories of what's happened to people who are following direct advice from a lot of these tools. And then sort of funnily enough, OpenAI is preparing a full policy blueprint for healthcare AI regulation, which I'm a little bit concerned about. I don't think this should come from OpenAI. This should actually come from the regulators. But again, a lot of the regulatory landscape is trying to sort of play catch up with a lot of technological advances. Now, why AI literacy matters. So most healthcare professionals are not actually adequately prepared for the AI era. A lot of organizations need to standardize their baseline AI literacy. So there's not a lot of info in terms of privacy, transparency, monitoring, the human into loop expectations, and all of that. So a lot of people can just copy paste information without actually having that human in the loop mindset of what am I supposed to be doing as the human that sort of inputs certain information into the AI tool and grabs outputs from that. There's a lot of shadow AI, so people using tools that are not necessarily vetted by the organization that they're using it for, and so this obviously has to be addressed. And obviously, there's a lot of burnout and staffing shortages that drive these unsanctioned adoption of these tools as well. And we know that essentially prohibiting the usage is not really working, but rather regulating the usage is the way to go. And AI is also evolving, as we've talked about time and time again, in terms of it going from an information gathering tool to something that can reason and judge and synthesize information together. And then without literacy, the healthcare providers can't actually critically evaluate the AI outputs, understand how to interact with AI, or catch errors that it might have as well. And in terms of general public, I showed you the data before. So a lot of millions of people are using these tools to ask health-related questions. These patients also need to understand that AI tools can hallucinate and provide incorrect information, that AI outputs are predictions, not diagnoses, that they don't have the context that your physician has based on the electronic medical record system that they're using or whatever else in terms of family history and personal history and surgical history you've given them. There are privacy implications of sharing health data with AI as well. And some of the patients just, they might upload their ECG without actually redacting their information at the top. And now the algorithm has access to your whole healthcare number and your name, and it can identify your ECG from that, for example. Now, where does that go, and how do these tools get trained on these, and whether like that information is now discernible and somehow someone can go in and grab that information? We don't know yet, but it is a possibility. And then obviously we have a divide in terms of digital literacy. So a lot of younger users are more comfortable, but all ages need skills for this. And then having that literacy for both the provider and the patient is going to be helpful in the sense that now people can interact with these tools responsibly. And then the healthcare providers can actually educate and train their patients in terms of what they can use these AI tools for. So people just are going to trust blindly or completely dismiss certain tools if they're not really trained on a lot of this. And why do we need it in Canada? It's we actually talked about the data in Canada as well in terms of what CMA has shown us, but like a lot of people still trust physicians as the most reliable source, but they can't always reach them. So then there are a bunch of people that are trusting the AI output as essentially the full truth, and people are actually knowingly using the tools that they don't understand, because 50% use it, 27% trust it. And then like these are essentially the pieces of data put together that show us that AI literacy is very important, and we need to teach AI literacy as much as we can going forward. And as part of this also is embedding this AI literacy in health education. Like I was mentioning before, we've been trying as part of a sort of a pilot project to do AI literacy lectures and a lot of different health related curricula. And we've gotten really good feedback from the students. But these are very fragmented still. There's not really a lot of validated healthcare specific assessments. There are some frameworks out there as part of, for example, this international working group on AI in medicine education. We've been developing some of these tools or frameworks for people to use in different organizations, but again, the usage of those frameworks are pretty fragmented still. And some of the key competencies that we need is understanding the capabilities and limitations of a lot of these AI tools, as we've talked about, recognizing biases in the data sets that we're giving into these tools, as well as the biases that come out of them, and then evaluating the health information that AI generates, and then knowing when AI is appropriate versus human judgment is actually essential. And that's why courses like the course that we've been teaching you guys actually exists. I'm just going to go through one or two more slides and then we'll take a break. But why this course matters, why are we teaching essentially AI to future healthcare professionals? Again, this is a repeat of what I've said before. AI is transforming healthcare, and it's doing it whether we're ready for it or not. And then a lot of people are using these tools for health related stuff daily. Lots of physicians are using AI, and so future doctors, nurses, researchers, they're going to encounter AI in their practice, whether they like it or not. This is the reality of the current world. So understanding AI actually helps them critically evaluate these tools before they adopt them. They can advocate for patients in an AI augmented healthcare system rather than the previous, I guess, the traditional, quote unquote, traditional health system. They can participate in development of these tools and also in their governance and regulation. And then they can recognize and mitigate some of those biases, errors, and ethical issues that we've talked about as well. And then what we hope that you've gained from this course so far is that foundational understanding on generally how AI and machine learning actually works, sort of understanding the real world clinical applications of AI, which we've gone through today a little bit, but you've seen these before as well in the previous lectures. Understanding some of those limitations that AI has, the hallucinations and confabulations, the biases, the quality of the data you're giving them. And then the ethical frameworks that you need to know to evaluate AI in healthcare. We didn't really go through a lot of these in this course. Like I said, that would require in and of itself a bigger course. But there are frameworks out there in terms of trying to figure out if is this tool the right tool to be used in this specific situation. For example, you need to use the right tool for the right scenario. And then hands-on exposure to AI tools that you can use in your career is something that we're hoping that you would be doing on your own as part of the assignment that you have as well. And then being an informed voice in that conversation in terms of trying to be that person that sort of advocates for responsible usage of AI. And so we're hoping that you're better prepared than most healthcare professionals throughout this, and you can actually venture out and learn in more of a self-supervised manner. This is my last slide before the break. And in terms of the bigger picture, like we've said before, they've been saying AI will replace doctors, especially radiologists and pathologists, for the past, I don't know, probably 10 years. That has not really happened. So we haven't really gone there, and I don't think that's going to happen that quickly. But essentially, the thing to understand is those that actually know AI are better equipped to be a better healthcare provider than those that don't. And then we need healthcare providers that actually can bridge that gap between technology and patient care, because we have these two fragmented areas of healthcare and AI technology, where you have the AI developers trying to build a solution for a problem that might not even exist, and you have healthcare providers that know the pain points, but they don't talk to each other, so they don't actually get this information to the people that are developing these tools to understand that these are the pain points and these are the problems that need solutions. So now that we've also taught you these things, this adds a bit of a responsibility to you folks as well, that you have a responsibility to your future patients to understand these tools more and understand how to use them, understand how to educate your patients on how to use them responsibly as well. And then your voice is going to be one of those voices in the healthcare system that's going to be involved in AI governance and policy and deployment and all of that. And we're hoping that through all of this, you're going to stay curious and critical and keep learning, because the field just keeps evolving. And I don't think anyone can really teach all of these tools in just one course. There's a lot that you can learn on your own in self-directed learning fashion, I guess. So we're hoping that you're going to keep doing that on your own time after this course is done as well, and as you go through your medical education or whatever else you're doing. Okay. I know our break is about 30 minutes overdue. So we'll do about 6-ish minutes, because I also want to hope to finish a little bit earlier than the exact 2-hour time frame. So we'll come back at 6:30 Edmonton time, which is in about 6 minutes, and continue from where we left off. But I'm still here if anyone has any questions. I'm happy to answer those. You can type it in the chat or unmute and talk. Okay. Are there any questions so far based on what we've talked about before we go on to chat a little bit about how you can start using AI and then go through a lab tour or multiple lab tours, I guess? Sounds like there are none. Okay. Feel free to just put it in the chat if you have any questions as we move along, or unmute and talk whenever there is a chance for that. But let's move on to this. Okay. So how can you start using AI? So again, AI scribes are in use. They might be coming soon to your electronic medical record, or you might already have them. Having said that, there is some, I guess, for the lack of a better word, controversy in terms of using AI scribes as students. For example, if you're a medical student and in clinic and your preceptor is using an AI scribe, usually people don't say anything, and you just use the AI scribe that they have because they ask you to use it. But the programs are trying to figure out how they can navigate the situation in terms of, well, what are the basic competencies that they want medical students to have as future providers is to be able to write their own notes and that sort of stuff and learn how to do that. So there might be some limitations and regulations in terms of what you can use and when you can use these tools. But just be aware that they do exist and you might be asked to use them or you might be asked not to use them. And it's going to be difficult to navigate that whole I guess gap between the regulatory sort of the regulatory stuff that you're going to be told versus the stuff that you're going to be told by your preceptors. But medicine is usually trying to navigate those gray areas a lot of times. So I'm sure you're aware of a lot of these. But you can urge your department to try them out once you have that sort of voice. And then I also talked about this already, that you might not be able to use them just because they want you to develop those certain charting skills before you get help. There's a lot of AI research that's happening. If you're interested, you can sort of get involved in those. You can contact different principal investigators that do this. You can ask around and find out what is already being used or trialed at your institution. And then there's a lot of like AI tools. There's ChatGPT and Claude, for example, that I've mentioned before. They're pretty versatile chatbots and AI assistants. Claude has a lot of different types of things as like a coworker, and then there's like the Claude Code where you can get it to help you with putting together code as well. I mean, ChatGPT has Codex too, which you can use. There's, I believe I have the Copilot in here. No, I don't actually. But like Copilot, for example, is another tool that you can use for that if you're trying to code. Perplexity is an AI-powered search tool. It can sort of get you a lot of research-specific things if you're interested. ChatGPT and Claude are also getting better with that, but you just have to be a little bit better with your prompting, and usually they're not the best when you're using the free versions. But just keep in mind, if you are at U of A or you have access to a Google Workspace through your university, you probably have access to NotebookLM and Gemini, and Google usually has agreements with these institutions that they're not training their models based off of whatever you're giving to their tools. So that might be a better way of using some of these tools if you have institutionally approved tools. NotebookLM is absolutely phenomenal with a lot of things that it can do. It's one of those grounded tools that you can use. You can give it your specific resources and just grab stuff from that directly. Illicit and Consensus are for AI research. You can use them for a lot of different things. Consensus, for example, can give you, I guess, the consensus on a specific topic. If you ask it, does whatever cause whatever, it looks at the literature and sort of gives you an understanding of if that's the case or not. It's usually good with things that we have a lot more evidence for, but it's getting better. And then Elicit can actually help you with a lot of research questions, writing whatever you've thought about, putting together papers and networks of papers as well. So and these are just only a few of the tools available. There are tons of other tools out there. The one thing that you need to be careful with is just trying to figure out how these tools have been developed, what are they being used for, and is whatever use you're trying to use them for the right sort of usage for that tool based on whatever data it's been trained on. And just also looking at the terms and conditions of what they're using your data for. And I understand that a lot of these terms and conditions are really long documents. You don't really have a lot of I guess time to go through all of this. You can use AI to summarize some of that for you and sort of grab bits and pieces of information from those to understand what they're doing. So, for example, I might have said this already, the paid version of ChatGPT doesn't technically train on your data unless you go and toggle it on. Or I forgot it's actually a toggle on or a toggle off. So just check to make sure if you're using that. But Claude, even in the pro version, it actually gets trained on your data. So regardless of whether you're paying for Claude or not, your data might be going to their servers to get extra training. I believe if you have the enterprise version, which is much more expensive, then it doesn't. But you got to check these things for a lot of these tools. Like I said, if you're at U of A, you have access to NotebookLM. Technically, we have agreements with Google that they don't train on our data, so you can use that with a little bit more peace of mind if need be. Okay, now let's do a very quick lab tour, AI lab tour in terms of the University of Alberta health research. So what's new in 2025, 2026? And the reason I have these two slides here are because most of the stuff that I'm showing in terms of the labs are actually ones we've shown last year as well. So this is just to give you an understanding of what has changed since those. So we have an AI and health hub, and they launched back in May of last year. And they have a profile of 120 plus researchers from 10 different faculties. And so that's a very good place to get involved if you're interested. They do have lunch and learns usually, and you can show up and learn about different things health AI related. At Ames, we actually do collaborate quite a bit with the AI and Health Hub as well. So if you're interested in doing anything as part of the students, we usually sort of facilitate the student side of things. So you can talk to us about that, or like I said, go directly to the hub. We have the Kipnis Health Research Institute that houses the AI and Health Hub, and also the Health Research Translation Unit, which I'm sure is going to try and use a lot of AI. Lots of new faculty members in medical AI. I do hear a lot of talks recently, or I have heard a lot of talks recently from a lot of newer faculty members that we've recruited from across the world that have been doing amazing work. So, and I'm sure they're looking for students or people to help out with projects and stuff. So if you're interested, those are probably the people to reach out to. And the U of A also had a partnership agreement that they just signed back in December with the University of California, San Francisco, to work on AI and viral disease research collaboration. We also have collaborations with companies like Moderna, which I will talk a little bit about more when we go through the labs as well. And then these are some of the, I guess, general highlights from the U of A. So Reason to Decide is a framework that's 40 times smaller than GPT-4 with better medical explanations. It's an algorithm that's been developed in-house. There's a machine learning algorithm that predicts all-cause death from ECGs that we've developed at U of A. There are models that predict opioid use disorder risk. There are models that have been developed for heart disease diagnosis and treatment. But like I say, these are just a few examples of the incredible work that's happening in AI at U of A. And I'm sure you know that U of A actually is pretty good worldwide actually in AI. So you're at a very good institution if you want to do AI work and you're interested in doing some health AI specific projects. So let's go through some labs. So this is the first lab is Dr. Hosna Jabbari's lab, the Cobra lab. So they do look at a lot of disease diagnosis and treatment, and they're trying to use a lot of RNA-based solutions and advanced computational techniques to do this. This is actually the lab that has collaborations with Moderna now, and sort of the major research areas they have are diagnostics and therapies from RNA, the advanced computational genomics that they do. They have machine learning applications, and they do a lot of bioinformatics and data science as well. And they've been working on a lot of development of vaccines, gene switches. They look at biological aging and early detection of some of the neurodegenerative disorders that we also talked about before too. And they have lots of collaborations. Like I said, some of these slides are from previous years, so I don't have their Moderna collaboration here, but they do collaborate quite a lot across the world. If you're interested, this is one of the labs. Another lab is Dr. Hussein Rouhani's lab, the Neuromuscular Control and Biomechanics Laboratory. And some of these slides are going to have acknowledgements under them. Those are usually the people who have kindly provided these slides for us. So I did include some of that. So for example, this lab, they work on exoskeletons. So these are wearable systems that are designed to provide physical support and assistance to whoever is wearing them. And they can have they can target different parts of the body, but they can also have different types of designs. And they can be used in improving the conditions of work or reduction of exposure risk to work-related disorders. And then finding the right combination for optimal support for a specific worker use case is a challenge within the exoskeleton field that this lab is trying to work on. So you have these, for example, like passive exoskeletons, and they have various industrial use cases. So they can, like we showed before in the previous slide, they can target different parts of the body, they can have different designs, or they can have different levels of torque support and angle engagement as well. And then they sort of evaluate a lot of these things through in-lab assessments when they do have these sensors that they use, but also in-field assessments when they sort of get the worker to wear these at whatever plant or factory or whatever they're working in, or work environment, and sort of look at them through the sensors that they have on them to see how they are performing there too. And then these are some examples so this is an in-field assessment of an exoskeleton, as you can see here. And I'll show you this in-lab one as well. So they have all of these other sensors in the lab too, where they can, and a lot of cameras and stuff as well to sort of look and see how these exoskeletons are performing. So if you're interested in biomechanics and biomaterials and overall biomedical engineering plus AI, this is probably a good area to be in. And then they also have these questionnaires from people that are wearing them to see like what are the regions of discomfort, and once they wear these tools, how do these exoskeletons perform and whether they are happy with them or not. So yeah, so if you're interested, that's the email address for the PI in this lab. And I believe you guys, I think you have the slides, so these should be on there. So if you need to contact these labs, you're welcome to. Blink Lab is one of the well-known labs at U of A as well. Dr. Hubert and Dr. Pilarski. If you have come to AIMS events before, you probably have seen Dr. Pilarski give a lot of talks. They do a lot of really cool stuff in their lab as well. So they use a lot of reinforcement learning and human-machine interfaces, and essentially trying to train a lot of these tools that they're building for example, exoskeletons to use this like intelligence that they are giving them through reinforcement learning or other types of AI tools to be able to use them in whatever environment that might be the case. Whatever, for example, let's say someone has a disability that they want to use a certain tool. So that's one of the things they do. So prosthetics is one of the areas they work on. So they want to sort of restore that dexterity that you probably would be losing otherwise using some of these prosthetics. There are challenges in their control and feedback. And sort of that feedback usually is a little bit clunky and can be choppy because of the errors in transfer, or even in terms of the delay that there might be. A lot of AI tools are really good at sort of reducing that delay to a certain extent and helping you with that. And so enhancing those prosthetic intelligence is actually one of the things that they're working on, and they can try and surpass human biological limits as well. And then this is for prosthetic arm control, reinforcement learning for prosthetic arm control. And that's one of the areas, like I mentioned, that they work on. The other thing they try to work on is adaptive rehabilitation technology. So prediction learning to, for example, improve the ability of users to switch between modes when they're trying to get some of these assistive technologies to help them. And then there's long-term brain body machine and brain computer interactions that they try to work on as well. The limb osseointegration is another I guess, technique that they work in this lab. It's essentially directly attaches prosthetic components to the skeleton. It's eliminating the need for a specific socket for that as well. So they're looking at evaluating the stability of these, how to optimize the control of that prosthetic, and also exploring the lived experiences and rehabilitation journeys of those people that are receiving these osseointegration tools. I'll show you this.
Artificial limbs are becoming increasingly advanced, yet they are still far from moving and feeling like an intact limb. Here at the Blink Lab, we take an interdisciplinary approach to develop and evaluate improved prosthetic technologies. Consulting directly with patients and clinicians, we ensure our research solves relevant challenges. Techniques like 3D printing allow us to take our solutions rapidly from the drawing board to the clinic. We employ machine intelligence to improve control of complex devices, allowing the user and the prosthesis to work together. By combining surgical innovation and engineering, we are developing technologies that allow prosthetic users to experience touch and movement from their prosthesis.
Okay, yeah, so you can see some of the stuff that they're working on. I'll maybe run through these very quickly. So this is a finger closing speed test. This is 1/8 of speed. And then this is the hand demo with the data glove. So essentially you have the glove on your hand, and then whatever you're doing, the device is mimicking exactly what you've done. So these are, as you can tell, these would be very helpful in surgical settings, for example. I do see a couple of things on the chat. So Canadian developed AI scribe for patients. I actually did not know about that. I'll check that link actually. Thanks, Chris. And then is there a PDF or website that has a list of all the different AI related health labs in the U of A? Unfortunately, not really. You can just find some of the PIs on AI and Health Hub, but that's also another project we have at AIMS to try and actually put together a list we're a national nonprofit, so we're trying to do this across the country, but we're going to collaborate with the U of A chapter of AIMS and try and put together something for U of A specifically. So stay tuned, and if you're interested in helping out with that as well, we're looking for people to help out with that. So in the process, you'll also find those labs for yourself too. So it's sort of like a two birds, one stone situation if you want to help out with that. So I know that's not directly the answer you were looking for, but yeah, that's something we're working on. This is another lab, telerobotics and biorobotic systems. So personalized adjustments to the assistance that's offered by the upper limb exoskeleton to a user. So you see that the user is already doing all of this, but it's just helping them with whatever they are trying to do as well there. And then I'll actually play these while I talk through. So these are lower limb exoskeletons that essentially they learn from the gait patterns of the person using them to shape the trajectory of where they're going. And then this is an intelligent walker that essentially personalizes to the person in terms of the mobility assistance and gait asymmetry. And then these are serious games for rehabilitation. So different types of tasks that you can do with a lot of these tools. Okay. And then rehabilitation of injured users is another area that this lab works on, as well as robot-assisted surgery. I'll show this guy. So for example, the Da Vinci surgical system, we know that, again, these are data from previous years, so this might have changed, but more than 60,000 surgeons have been trained for its usage at the time that we put this together, and more than 10 million surgical procedures have been performed. Again, I'm sure the number is way higher than that right now. But I'm sure you've seen the surgical instruments where the surgeon sort of teleoperates the instruments by sitting far from the patient, essentially, at the robot. And doing that, and then these are surgical skills assessments and transfer. So they get these algorithms to sort of learn from the user and transfer skills from expert to novice through that collaborative human robot execution. And this is going to be a game changer in terms of the usage for education and a lot of like surgical education that we've been trying to do in the past. And then learning from demonstration. So you can do a perfect and an imperfect demonstration and get the robot to sort of learn from both of those. So that's like the imperfect demonstration here, and that's the perfect demonstration. And then here you have a demonstration for the tool, and then now the tool actually reproduces whatever you've trained it on. And then surgical simulation and autonomy. So these are surgical simulators that can enable the training of surgeons in training without the need of these real world environments. So you can have these simulated surgical environments where you can practice your surgical skills. And that's that for that lab. Dr. Russ Greiner, we have actually, Russ has been one of the major supporters of AIMS since day one, actually. His lab does a lot of AI and health stuff. I'll go through them a little bit quickly, but again, you have these slides to go through on your own time if you need to. But they look at treatment prediction, for example, to identify the treatment that will lead to the best outcome for a patient, regardless of what that treatment would be, what field that treatment would be in. And then they look at counterfactuals. I'm not going to go through the math and of all of this, but this is one of the counterfactual regression is one of the areas they work on. They look at survival prediction. This has been one of the areas that Russ's lab has actually worked on for a long time as well. So essentially, does person X develop disease Y? Has been the question that we've been asking for a long time. But the better question is, when does that happen? And so we sort of try and predict that time to onset, or rather, Russ's lab tries to do that. And it can actually handle censored data that have been lost to follow-up, for example, this way. So this is one of the areas that they work on. Some of the examples is death from various cancers, COVID-19, or coronary artery disease, all-cause death from ECG scans, as I was mentioning in the beginning of this set of slides. And then looking at breast cancer onset, hospital readmissions, time until hospital discharge, and that sort of stuff are some of the projects that they're working on in Russ Greiner's lab. And then some of the challenges, you have high dimensional data. For example, you have genetic data in there, you have signals, and you have images or slides. So there's a lot of multimodal problems essentially happening there. And then depending on the question, the types of models you can use are also different. So it's important to be able to evaluate model performance on in terms of whatever question you're asking or whatever types of data you have available to you as well. They also work on epidemiology. So for example, they did do a lot of COVID-19 specific work a while ago, but some of it is still happening. And then another aspect is metabolomics. They do actually collaborate with a few metabolomics labs and look at the role of metabolites in health and efficacy of certain treatments. They do collaborate with David Wishart's lab actually to develop some of these tools that they can look at mass spectrometry data, or sort of effectively work on a new class of compounds. And then general examination of metabolites is another aspect of their work too. And then in collaboration with the Department of Psychiatry, they also do work in computational psychiatry as well. So they've been trying different types of models, AI models, for detection and diagnosis, prognosis and treatment, sort of public health aspects, and also supporting the research in the area as well. And then prospective prediction of mental health onset or precision of public health have been some of the examples of studies they've done. Yeah, so they've used machine learning models to predict mental health crises from electronic health record systems, and also prospective prediction of PTSD diagnosis from those types of data too. Yeah, and these are some of the papers that they've published previously. And then they've also done screening for alcohol use disorder as well, using both genetic and phenotypic data too. And they have these classification tools that they have grabbed from those. Okay. That is it. That was a very quick run through of all the, not all, but most of the medical AI labs at the U of A. This is the slide you know what to do with. So please scan the QR code and go to the form to give us feedback. If you are a medical student claiming credit for this as part of your electives, please make sure you choose MD student in the first question so you can actually answer the attendance form as well. And then overall, we're looking for more feedback from those of you who are taking the course. We are going to do a gift card draw in the end too. So you can submit up to 15 entries into the end of the course draw by completing the feedback for all of the sessions, and also the end of course feedback that we'll send you, which is going to be 10 extra entries there. While some of you are doing this, I'll see what is in the chat. Okay, Chris is asking, you mentioned the slides are available. Is that on the AIMS website? Yes, we will have them on the AIMS website, and the recording is going to be available on the website as well. Hopefully whenever I get to it. So we'll put that up in there. But yes. And then yeah, Ying actually put the link to the form in the chat as well. So if you haven't seen that, if you couldn't do this from the QR code, you can grab that link. And I'll move on to this. Again, another reminder, the assignment is due April 5th. Like I said in the beginning, this is our last session of the course for this year. Thank you again for being a part of the course. Thank you for learning with us. I hope that you've learned lots through this course. Yeah, those of you who are med students, again, claiming credit for your elective time, the assignment that you're supposed to be handing in is due April 5th by email to Ying. You've gotten emails from Ying before, so you know how to reach her, but if not, I will show this as well. So that's my email. That's the organizational email that we have if you have questions for anyone at AIMS. And then we're always looking for more people to join our team. So if you're interested after learning all of this about medical AI, we're looking for you. So we'll be happy to have more people, especially those that have taken the course and know a little bit more about what we do to be a part of our team. But I'll leave that there. Again, if you have any questions about the assignment or about any of what we talked about, feel free to reach out to me or Ying or Gulnaz, or even just email hello@AIMS. One way or another, they're going to find their way. Your questions are going to find their way to the right person. But yeah, happy to answer any other questions. I know we're at time, but happy to answer any other questions if anyone has. But otherwise, thank you again for being a part of the course. I hope you learned lots, and please keep in touch, and please go on and learn more on your own through self-directed learning on AI in medicine. Thank you.